Thank you, and greetings from Memphis, Tennessee. It's great to be with you today, and thank you to the organisers for the opportunity to talk about measuring and managing CMT of childhood. So today I want to cover 4 topics. The first is a focus on pediatric CMT and why that's important, how we develop trial endpoints for CMT. In particular, I'll talk about one scale, the CMT pediatric scale, and then I'll finish off with different management strategies for treating CMT and the really exciting opportunities in the future to improve the care of all people with CMT. Okay, so the reason that we focus on pediatric CMT, and the reason that I've focused on pediatric CMT for over 20 years, is because there is great opportunity to improve the condition if we can intervene early or treat early. So to remind you, CMT, there are many types, over 130 different mutations now causing CMT. It is a disease of the peripheral nerves, predominantly demyelinating and or axonal. And my area of interest in particular are the different clinical problems. So the really high arch foot deformity, which we know is due to muscular imbalance. You can see the MRI there on the top right showing that the muscles are selectively weakened in CMT. So some muscles are stronger, some muscles are weaker, and that causes these types of deformities, such as the high arch foot deformity, and also hand deformities. So you can see there a picture of a hand with some weakness, but also some deformity. Increasingly, we're seeing bony and problems around the hips and the spine. So even though it's a peripheral nerve disease, in other words, affects the nerves furthest away from the spine and brain, increasingly we're seeing bone problems near the spine, such as hip dysplasia. And you all know this, and we see this in clinic, is that CMT affects multiple family members across multiple generations, and we're quite interested to see how the disease progresses in different families and whether intervening at a younger age could have the best chance of success. Okay, so most of the research that I've been conducting and many people in the world have been conducting in the area of CMT is done as part of the Inherited Neuropathy Consortium. The Inherited Neuropathy Consortium has sites all over the world. There are 28 sites, and we've been assessing patients with CMT, both children and adults, for over 17 years. So we have over 1,000 children with CMT that have been assessed over many years, and also over 6,000 adults with CMT who have been assessed over many years. Part of the work we do in the Inherited Neuropathy Consortium is also developing new ways to measure CMT, looking at new genetic causes of CMT, and also looking at how CMT changes over time. And the point to all this is to become clinical trial ready, where we're trying to really understand the severity and the progression of CMT. So when we intervene with treatments, we can really make sure the intervention is going to have the best chance of success. Okay, so my area in particular of focus is developing clinical trial endpoints for CMT. So these are the measurements that we use in clinical trials to see if the treatments work. So those treatments could be drug treatments, surgical treatments, rehabilitation treatments, lots of different types of treatments. And what I really focus on is how we measure if the treatments work. So one way to think about that is looking at how the FDA in the US defines a certain type of measurement called a clinical outcome assessment. And it's really important that this type of measure describes how you, the patient, feels or functions. It's incredibly important if drugs in particular are going to be approved by the FDA that they measure parameters that matter to people. And so it's really important that we measure how people feel or function. The categories of clinical outcome assessments are performance outcome measures, so where people give their best effort during an assessment, and I'll talk about this in the context of CMT pediatric scale, the CMT PEDS. There's patient-reported outcome measures, and so one example is the pediatric CMT quality of life measure that children fill out themselves. And there's the observer-reported outcome measures where the parent can fill out on behalf of the child or in addition to the child. And then there are clinician-reported outcome measures where the doctor does an assessment and makes a determination around disease severity and progression, such as the CMT neuropathy score. The newer types of measures is where we're really trying to make the most of digital health technologies and thinking about how digital health technologies, which are systems that use computing, connectivity, software, and sensors in the patient environment. So that environment can occur in the hospital, where we might measure gait or how somebody walks. We might measure mobility or how somebody functions, but using digital technology such as 3D motion capture, different applications on phones, different video applications, different digital measures. And I think probably the most exciting area for digital health technologies is in the sensor-based world, where people wear sensors at home and we can measure a lot of how people walk and function in the home and in the community. And the importance of these types of measures is that we're measuring more of a patient's life, and so we can understand more about problems people are facing and more about if the treatments are working. And this type of measurement is called passive acquisition. So we're observing function, and we're observing gait, and we're observing how people operate in their day-to-day life. Okay, and this is a really busy slide, really just to demonstrate that we apply a strict scientific approach to developing trial endpoints. And so we need to make sure that the measurements we develop and then use are reliable and accurate and valid. They can be performed by multiple health professionals in multiple countries using standardized equipment. And so much of what we do is trying to make sure that everyone around the world who is involved in CMT research can do the measurements the same way. There are a lot of measurements out there that have certain restrictions in that they can only be done at some centres and they can only be done by some people. And really we think that the future is trying to get many, many sites in many parts of the world doing the measurements the same way, which is excellent for multi-centre clinical trials and also very good if we find a solution to a problem in, say, England, and we want to transfer or translate those findings into Europe and beyond. And so it's really important that we're all doing things the same way. We also want to make sure that when we collect these measurements, we're not measuring anything more than we have to. So in the past, we've assessed patients for several hours to understand as much as possible about what's going on. But through a correct statistical methodology, you can reduce the number of measures to get the same amount of information. In other words, in children, we don't want to be measuring children for much longer than 30 minutes because they get tired, they get cranky, and they don't want to do it anymore. So a lot of our scientific method here is to try to shorten the measurements, make them engaging for the child, and also can be used worldwide. Okay, so one example is the CMT pediatric scale, or the CMT PEDS. The CMT pediatric scale is an 11-item scale, and it measures hand dexterity, so how your hands and fingers function with these two tests. Then there's strength tests of hand grip, and then also foot strength, which we've got plantar flexion there and dorsiflexion. We also have 2 measures of sensation, using a pinprick and a vibration to see how well you feel. We have balance tasks. We have some walking tasks, such as walking on heels and walking on toes. We have a jump task. And then finally, we have the 6-minute walk test. So these 11 items originated with around over 100 items. And over 15 years, we were able to reduce the items down to 11. The whole test can be done in 30 minutes. And as you'll see, it's an important scale to understand disease severity, progression, and response to treatment. So on this slide here, you can see that the scale, which goes from 0 to 44, differs between patients with CMT1A, CMT1B, CMT2A, CMT4C. So as you'd expect, different types of CMT present differently, and this scale can differentiate between different types of CMT. It can also differentiate the rate of progression. So these different colours here are the different types of CMT over 2 years, and you can see that different types of CMT progress at different rates. And then this scale is on a digital or paper-based format. So to look at a bit more, looking at those coloured lines, you can see here that for CMT1A, the most common type of CMT, this scale progresses about 2 points over 2 years. Whereas for patients with CMT2A, this scale progresses 3 times that. And so that's, as we would expect, patients with CMT2A are a little worse and they progress a little faster. And this scale can pick that up. So that's really important when we're looking at including this type of measure in clinical trials, because we want to make sure that we measure the severity of the disease, the progression of the disease, and then most importantly, the response to treatment. We also know that of those different items in the scale, the foot dorsiflexion strength, the balance tests, and the long jump are the most sensitive items to change. So they change the most over time. And then we did a little analysis here to see those who wear orthotics or ankle foot orthoses, those who have had surgery, and those who haven't had any intervention, whether the disease progresses at the same rate. The answer is yes, the disease progresses at the same rate. However, the starting point is different. So those who have surgery are generally worse off on the scale than those that haven't. Okay, now, an important part of scoring this scale, because remember the challenge with children is that they grow and they develop and they change naturally over time. And then if they also have CMT, that natural rate of progression can be confused with growth and development. So what we do with this scale is we score it based on age and sex-matched healthy controls. So we really have a relative understanding of how each patient is progressing compared to people that don't have CMT. And the way we've done that is collected a large battery of normative reference values, so in children and adults without CMT, called the 1000 Norms Project. We've actually generated over 1 million data points of people without CMT across a whole range of different measures, so then we can understand exactly what to expect when you're 5 years old, when you're 10 years old, when you're 20 years old, when you're 70 years old. So we therefore know that if there's an impact or a response to treatment, we know that it's because of the treatment and not because of the child naturally getting older, getting stronger, unrelated to having CMT. And then all these measures get put into an online scoring platform called clinicaloutcomemeasures.org, where you can essentially derive the scores for each of the scales we've developed, where you put in the patient's measurements, it generates converted scores, and then here you can see for the CMT pediatric scale, the 11 items are put in, calculated, then instantaneously we get that total score from 0 to 44. And we even can download a file for the patient. Okay, so moving along, one of the challenges, of course, in assessing children with CMT, like assessing anybody with any type of condition, is that there's a whole range of progression, what we call variability. So what we've done here is really worked out who is most likely to improve in a clinical trial. And that's called prognostic enrichment. So we really dig into understanding which subgroups progress fastest. There's something called the SRM, and the higher SRM, the better. And you can see when we look at the entire sample, the SRM is 0.5. But when we look at younger kids with milder disability, we can increase that SRM significantly. And that means that if a treatment is going to work, it's most likely going to work in that particular group. And that's important for clinical trial design. Okay, so we also have an infant scale. This is for 0 to 4-year-olds. We have an adult scale. This is for people aged 18 years and over, based on similar design parameters to what I just described. We've translated these scales into different languages there. You can see for the pediatric scale, we have Spanish, Italian, Portuguese, and then the users are increasing every day. We have over 1,300 users of these scales and using of the platform. And at the moment, we're doing a study to certify health professionals around the world who are using these scales reliably, because we want to help pharmaceutical companies in particular be trial ready. Okay, and then we've got digital health technologies, which I've talked about a little bit already, such as physical activity monitors. These inertial measurement units can really understand how function is happening in the community. And we have smart watches, which I'm sure many of you have used, such as the Apple Watch. And with these digital health technologies, we can already see that when we measure people with CMT at home, we can get a really good understanding of different degrees of severity related to physical activity. We can look at their step count in relation to disease severity. And we can also look at balance parameters and see the people with more severe CMT have more difficulties with balance. Okay, so to finish off with, I wanted to cover off on some of the treatments that we've been looking at for CMT. It's an exciting time for CMT with many drug studies underway, particularly early phase clinical trials. But over the years, we've been running other trials to look at rehabilitation strategies to improve ankle flexibility. We looked at different orthotic types, including using 3D printing. Looked at exercise to improve muscle strength. Looked at surgery approaches for hip problems, for hand problems, for foot problems. We've looked at botulinum toxin or Botox to see if we can rebalance the imbalance that causes that high arch foot. And many years ago now, we looked to see if vitamin C helped CMT, and more recently whether vitamin B2 helped CMT. Just to show you a couple of slides on exercise, we found that if we use a exercise training cuff on children's feet with CMT and ask them to do exercises where they lift their foot up and down, and then over time we increase the weight, we found, and then we measured dorsiflexion strength and MRI, we found that children who received the exercises that increased in weight had a significant increase in their muscle strength compared to children who didn't have the weight increased. And then you can see this green line is the natural rate of deterioration for foot strength. So we can see here that exercise really helps children with CMT. And looking at MRI, we could also show that there were no problems with overwork weakness or any concerns with damage to the muscle. Okay, now all of this information is in this one publication, which is a best practice guidelines for CMT. It's the first one in the world to look at the best practice guidelines for CMT. This is an excellent resource to share with your health professionals and doctors to let them know the latest information on caring for people with CMT. Okay, I just want to finish off by thanking my new team. I moved over to Memphis last year. We've been building a team in our human performance, gait and mobility labs, and all these people are doing incredible work to help patients with CMT and other neurological conditions. So with that, I'll conclude, and I'll thank you very much